Hi, I am Dr. Kirkpatrick, Carol Kirkpatrick, and thanks for joining us this evening for the lipid panel. My very good friend, Dr. Dan Safer, asked me to moderate tonight, and I am joined by some wonderful panelists, experts, who I plan on learning a lot from tonight as well. I'll do introductions in a minute, but I did want to do a brief reminder about what the lipid panel series is all about. I think we're all aware that sometimes being a lipidologist can be a lonely venture where we all are. And so luckily we can learn from each other. And it's kind of like when we do CB ground rounds, these monthly meetings are lipid ground rounds. And so it's meant to bring cases forward and having typically either from a lipid scholar or an early career person presenting a case. And then we have panelists who help discuss that case. And then that way we can learn from each other. Sometimes it's nice to have patients that bring us some interesting experiences where we can learn from those nuances from each other. So that's the whole point of the lipid panel series, once a month. And so tonight's lipid panel series is on hypertriglyceridemia. And we have a really interesting patient that we're going to present. I am joined tonight by Doctors Taher, Modarressi, and Zahid, Ahmad. And I am going to introduce them. And then once I've done the introductions, we're just going to go by first names because we're all friends here. So let me introduce Dr. Modarressi first. He will present our case tonight. He's a clinical lipid specialist and endocrinologist, and he has a very busy cardiology practice in central New Jersey. He recently co-authored a review paper on hypertriglyceridemia, focusing on the endocrinopathies associated with hypertriglyceridemia. And then Dr. Ahmad is our discussant. He's a clinician scientist in endocrinology at UT Southwestern and has numerous publications. He's researched and written about the characteristics of individuals in his health system who have very severe hypertriglyceridemia. So he's going to bring the expert view in tonight with our case that we're discussing. In addition to being a clinical lipid specialist, Dr. Ahmad is also co-chair of the FNLA Diversity, Equity, and Inclusion Committee. And so hopefully we can discuss the healthcare disparities as we go through our case tonight as one of the challenges in the management of hypertriglyceridemia. So we were expecting Dr. Michael Miller tonight as well. You may have seen that in our email promotion. Unfortunately, some circumstances arose that prevented him from being here tonight. And then I am Dr. Carol Kirkpatrick. I am a clinical lipid specialist and registered dietitian nutritionist. I was faculty at ISU, Idaho State University, as well as the Wellness Center director, but I recently left to join Midwest Biomedical with Dr. Kevin Mackey, our current FNLA president, and I'm enjoying that as one of his clinical scientists. I do still teach at Idaho State University. I teach an evidence-based lipid practice every spring, and actually have several of my FNLA friends who come and guest speak. So I might reach out and ask our expert panelists tonight to do that as well in the spring. So without further ado, I would like to turn the time over to Taher to tell us about your patient. And I will just tell me when to go forward on the slides, or I guess I'm in control, so.
Yeah, perfect. Awesome. Well, thank you to all the attendees for joining us. Thanks to the FNLA, in particular to Dr. Safer for inviting me to present this case. Really, really interesting case. And Carol, I'll let you cut me off wherever you need to sort of clarify anything, or if you wanted to discuss any of these points. But briefly, this is a 44-year-old man who was referred after a lab workup revealed severe hypertriglyceridemia. He was having abdominal pain, and that's the initial reason why he had these labs done. He had not actually received any sort of medical care for a number of years. He was not aware of any known diagnosed medical conditions, and he wasn't taking any prescription medications. Had no recent illnesses or prior hospitalizations or surgeries, generally good health until then, and did not remember any major medical issues over the course of his life. He specifically denied any history of diabetes, atherosclerotic cardiovascular disease, or acute pancreatitis.
So I'm just going to, excuse me, ask some questions here. And I know, Zahid, you are supposed to be the expert here, so I don't want to put you on the spot the whole time. Taher, I would love to have you share your thoughts as well, but is abdominal pain typically associated with hypertriglyceridemia, or what do you all think is important with his clinical history here with his abdominal pain that eventually was shown to be related to the hypertriglyceridemia?
Yeah, that's an interesting question. So obviously we think about pancreatitis and abdominal pain, but it doesn't seem like, at least the way it's written here, it's not so serious that it could be pancreatitis. It could be. I mean, we'll find out more. There are plenty of reports of people with high triglycerides having abdominal pain. Whether or not it's directly related or it just happens to be that the same people are having abdominal pain that have high triglycerides, they may have other issues too. I think it's kind of unclear. I think as we learn more about this case, we'll get a better sense of how related the abdominal pain was to the triglycerides.
So I was going to say exactly that. We kind of need more information from our patient to help kind of elucidate what's going on.
We have, in a sense, a little bit of bias because we're presenting this case at an MLA session, but always good, just like you're both suggesting, to keep things broad if you're seeing people in general medicine context. And remember, there's other stuff that can cause abdominal pain. One quick question I had, I guess, for the both of you is, when I was getting my lipid education, what does severe hypertriglyceridemia mean? For somebody who's just starting off, a lot of numbers are marked as high, and what does that actually mean in terms of ranges or what to expect from a panel that comes back at severe elevations?
Yeah, that's another good. Oh, sorry, Carol, go ahead.
I was just going to say, I know it's kind of evolved over time, and I know most recently our recommendations do show that we want. I mean, obviously, optimal is less than 100 in a fasting state. So, and that was back with Dr. Miller and his paper that he wrote in 2011. I think their algorithm was beautiful in the way to kind of compare fasting and non-fasting levels. If we're looking at severe hypertriglyceridemia now, it's really, essentially over 1,000. And correct me if I'm wrong, Zahid, but that is where I would consider severe hypertriglyceridemia. Then there's moderate, which, the cutoffs are above 175 now is considered elevated. And then up to 999, that's kind of that moderate before we get severe. Is that how you would answer that?
Yeah, that is pretty much how I look at it. I was, however, reading the recent ACC guidelines on ASCVD risk and hypertriglyceridemia, and I guess they define it a little bit differently. They say anything above 500 is considered severe, and above 1,000 is especially severe. I mean, and Haynes also has definitions. They call severe as above 1,000, and I'm trying to remember if they call it extremely severe or something like that as above 2,000. And maybe an endocrine society, their guidelines are very old, but they also define it kind of that way as 1,000 as severe. So it depends which guidelines you read. I think anything above 500 deserves our attention, and above 1,000, you really worry about pancreatitis.
Mm-hmm. And I was actually
There's
just
a question in the chat about millimoles per liter, by the way, in terms of units. So just to clarify, 10 millimoles per liter is about 880, if I remember correctly, milligrams per deciliter. So 1,000 milligrams per deciliter that we're mentioning here is about 11-ish millimoles per liter, and 500 would be about 5.5-ish millimoles per liter.
Thank you for paying attention to the Q&A. I'm supposed to be doing that, so thanks for the reminder. So I did want to clarify that some patients can experience pancreatitis even above triglyceride levels of 500 milligrams. So I think it's definitely the risk increases when we are looking above 1,000, but even for some patients above 500 can be a concern. And that is really when we want to start taking proactive steps to prevent acute pancreatitis. Okay, well, let's find out a little bit more about our patient, unless you guys have anything else to say on this slide. We ready to go forward?
I guess I have one more question about this, which is, again, when I was going through the lipid education courses, I heard a lot about these, monogenic triglyceride related disorders, and a lot of it seemed like rare stuff I'd never seen. But I just have a quick question about the fact that he's 44 and this appears to be the first thing that's coming up. How is there any pertinence to that? Can certain genetic conditions present in this age range, or are there other things that fall a little bit lower down the differential if we assume that this is a lipid-based condition that no longer are pertinent in our thinking when we think about first presentation at 44?
It's actually an excellent question.
Maybe I can take this one since I have seen, we've been doing genetic testing at our institution for a long time. So most of the cases of familial chylomicronemia syndrome, or FCS, that would be the most, that's not the right way to say it, but it would be the clearest monogenic cause of high triglycerides. And that's usually mutations in lipoprotein lipase, but it can also be ApoC2, GPI, HBP1, LMF1, and ApoA5. And most of the time, they start having some manifestation early in life, in childhood, not all the time though. And so it is possible. 44 would be a little bit older than I would expect, but it's still possible. I mean, we do have some, I have seen at least 1 or 2 cases of genetically proven FCS where they've never had pancreatitis. And then the flip is, we've seen the 6-month-old with triglycerides of 6,000 and pancreatitis. And so, there is a spectrum. The other monogenic things that you may have learned about Taher are things like genetic lipodystrophies. Especially in men, that is a little bit harder to pick up just by looking at them. In women, it's easier, but in men just tend to, they may just look muscular or something. And so that could present a little bit later, and then there may be monogenic diabetes things that may present a little bit later as well. So it's certainly possible that it's monogenic, but my experience with genetic testing is that the vast majority of time is polygenic, not monogenic.
It's an excellent point, though. Thanks for asking about the age. Anything else before we move on? Taher, good? Okay, we did have a question in the chat. Someone wants to know a little bit more about this patient and the alcohol use. So let's see. We have events leading to the initial clinic visit first. Anything you want to point out here?
Yeah, so I just wanted to characterize some of the events that happened, and in particular how he felt. And the question about alcohol is a great one, which we'll come to a little bit later on in this presentation. So good on whoever asked that for having that at the top of their head. But just as background, so for approximately 2 weeks, he had what he described as near constant sharp abdominal pain that he felt diffusely throughout his whole abdominal area with radiation to his back. He never checked his temperature, but said that he did feel feverish at times. Notably, he did not have any significant nausea, vomiting, or change in his bowel movements, and he did not have any chest pain or shortness of breath. His urinary review of systems was also unremarkable. Let me pause there and see if there's anything that either of you would like to clarify here.
Well, if he was having full-blown pancreatitis, I guess I would have expected him to have nausea or maybe vomiting. So maybe it's not full-blown pancreatitis. Maybe it's a mild case or something. I mean, patients do talk about that, how sometimes they have milder cases at home. I'm not sure how safe it is to stay at home and deal with it yourself, but many patients do that.
So that was one of my questions is, I mean, could it be that as far as we know, he has not had a history of pancreatitis, but knowing that he didn't have such severe symptoms, would we worry about sending him to the emergency department, or do you all have concerns that he has not gone to the emergency department?
I think off the top, I mean, I'm always, surprised at what some patients will deal with in the comfort of their own homes. If I had 2 weeks of what he described, usually would have myself presenting. I think most patients that I see in my clinic will present to some form of acute or semi-acute care a little bit faster than this. But, it is something that we see from time to time is patients just saying, hey, I'm going to deal with this on my own. And we'll have a little bit more clarity in regards to this later in the case. But Zahid, is this something that, for your patients, have an issue? Is this something that you usually ask people to sort of seek emergent care for, or no?
Yeah, well, if they've had pancreatitis in the past, I would ask them to go to the emergency room. And if they don't want to, I would at least order, some labs, complete metabolic panel and a lipase, and amylase maybe too, and lipid panel to see where their triglycerides are. But I would make sure they get a workup as soon as possible. Yeah.
Fantastic. Okay. Shall we move on, learn a little bit more about our patient?
Sure.
Okay.
So for social history, so he worked as a construction laborer, and in general, in the preceding weeks before his symptom onset, he really had no limitations in his day-to-day work, worked pretty comfortably day-to-day, and it was heavy manual work. He lives with his boyfriend. Alcohol, he drinks 5 to 6 drinks daily after returning from work, at least 4 days of the week. In general, minimal exercise outside of his day-to-day job. He did have a history of anabolic steroid abuse, but this is something that he says, he denied having this. I'm sorry, he's an active weightlifter, but he denied having any history of anabolic steroid use, and lifelong non-smoker.
So this answers the question from our attendee regarding the alcohol use. So I guess, how does that contribute to how we're learning about our patient? Does that make you think more of a concern regarding his hypertriglyceridemia and his abdominal pain? Would there be other reasons now for his abdominal pain to be would be thinking something else for a differential diagnosis? What are your thoughts?
Yeah, so this does give me a little differential diagnosis to work with. So certainly, alcohol can cause pancreatitis itself, but it's a more common cause of pancreatitis than just hypertriglyceridemia is. But of course, alcohol can raise triglycerides, and that can lead to pancreatitis as well. And so this could certainly be hypertriglyceridemic pancreatitis, could be alcoholic pancreatitis, could be alcoholic and hypertriglyceridemic pancreatitis. I guess I would have expected his symptoms to be a little bit more severe if that was the case, but maybe not. Everybody's a little bit different. This weightlifter thing also brings to my mind lipodystrophy, because some of the patients with genetic lipodystrophies, especially the men, the ones that I have seen mostly during my training, many of them were actually weightlifters because their muscles pop out like crazy. And many of them have won weightlifting competitions. There's even an Olympic athlete from Canada who had lipodystrophy. It was a woman, not a man, but if you ever saw her, you would be very impressed with her, with the muscles that she has. And so I think being muscular gives some of the lipodystrophy patients confidence, and that makes them work out harder and do all these competitions and stuff. So so in my mind, there's two things that could be leading to his high triglycerides: alcohol and maybe lipodystrophy if he has lipodystrophy. And then of course there's other things. He could have undiagnosed diabetes. He could have undiagnosed hypothyroidism, which can manifest in a lot of different symptoms, including abdominal pain or diffuse body pain. I think those are kind of the main things that come to my mind.
I think that's very helpful. Taher, do you have anything to add before I ask a question from the audience?
No, I think Zahid really captured it well, where you start sort of narrowing in on what could inciting factors be. Even before we see labs, we have sort of this evolving differential diagnosis. And I think once you get points like this is sort of what we do with all of medicine. You get aspects in the story that then start moving that differential. And I do think, just like Zahid was saying, that the alcohol intake certainly pushes that higher, either as sole or contributing factor for what he's dealing with.
Mm-hmm. And I also really want to emphasize the point that Zahid made about individualizing the patient. So hopefully that's going to be a theme as we move forward, is that it's really important, regardless of what we learn from textbooks or lipidology classes or whatnot, each patient is potentially, is unique, and we really have to kind of look at their particular symptoms. So we do have an attendee. Clearly, the alcohol can be playing a role here with the hypertriglyceridemia. We have a question about his dietary pattern, and specifically what types of fats is he consuming. I don't know that we have a lot of that information for this patient.
That is a very good question, though, because high carb, high saturated fat diet certainly could be making things much worse.
And I'm glad you mentioned saturated fat, because I think some people think it's a high total fat, and it's not necessarily always a high total fat. And I absolutely agree. I didn't mean to cut you off. Sorry, Zahid. I just realized I cut you off there. But clearly, carbohydrate can play a role as much as alcohol with triglycerides, especially if it's a highly refined, high in fructose. Fructose especially can contribute to hypertriglyceridemia. But a lot of people think it's a high total fat. And in some patients, that is a concern. Like you mentioned, FCS patients, we do really want to pay attention to their total fat intake because of the chylomicronemia syndrome that they're experiencing, and they just can't metabolize a high amount of fat. But saturated fat specifically is something we want to pay attention to. So anything you want to add to that now that I finished?
No, thank you for expanding upon what I said. That's much more than I intended to say.
Okay,
I appreciate that.
We worked out well together then. But I do think it's a very good point. We do want to know more about this patient's history in terms of their dietary habits. We just don't have a lot of that for this patient, but it's clearly something that's important. Okay, shall we move on? Let's learn a little bit more about this patient with what he did before he presented.
So as you'll see, this patient really, did a lot of stuff that a lot of our patients won't do. Really significant self-directed interventions. But so prior to even receiving medical care, he received some lifestyle change advice from his boyfriend, and that really included alcohol changes, which I'll review. But his boyfriend actually had pancreatitis due to alcohol intake, acute pancreatitis, and suggested that the patient stop his alcohol intake and really change his diet to just soups and clear liquids, which the patient did for several days. So the follow-up evaluation and the lab testing, we'll see sort of the changes in that. But I just wanted to pause here and reflect on this in terms of the changes that he made, the specific choices of those changes, and why he may have made those changes.
Do you want to point anything else out, or just give everyone a minute to kind of take it all in?
I was passing the ball over so that you guys can expand on that. Like why specifically these changes? If this patient had called me and I had suggested something similar, why would I suggest those particular interventions?
Yeah, well, more than likely his boyfriend already knows what happens when you get admitted with pancreatitis.
Right.
That you can't eat anything, and of course in the hospital you're not going to get alcohol, and so they kind of knew how to treat it at home. And I'm always pleasantly surprised at how smart people are. They actually often make the right decisions without doctors. And nowadays, not everyone has access to healthcare. We wanted to talk about disparities. So when people don't have access to healthcare, they rely on their boyfriends and their friends and family to give them advice like this. And they rely on the experience of others to figure out what to do. And so that might be, I don't know his socioeconomic status, but that might be the case here, that he was relying on other people's experience so that he didn't have to engage the healthcare system and accrue high bills and everything. But I do want to point out though, because this is very important information that's on this slide. This is especially critical when we're going to look at his triglyceride levels, because we have to keep in mind that we're not going to see his peak triglycerides. He's already stopped the alcohol. He's already changed his diet to one that probably is very low in fat. And so we're probably going to see triglycerides that are 50% or more, or 50% lower, or maybe even lower than his actual peak. And I think people forget that, because I get calls from my colleagues in the hospital saying, oh, the triglycerides are only 500. How could that have caused pancreatitis? And I'm like, well, when did you check it? And it turns out they checked it on day 3 of hospitalization after the patient had been, not eating or drinking anything for several days at home too. And that's not their peak triglycerides. 500 probably didn't cause the pancreatitis. It was probably 2,500 or something like that.
So
Anyway,
what can you expect in terms of the tempo of triglyceride lowering when people make these kinds of changes? Is it the same for everybody in terms of what to expect? Is there a range? But what do you usually see?
well, with NPO status, because I usually reference that, with NPO status, with not eating anything, you can expect a 50% drop in triglycerides over 24 hours. And so I often, when I'm rounding in the hospital and we see patients with pancreatitis, I actually, just for fun, I have the team predict what the triglycerides are going to be on like day 3 or day 4. And we're almost always right, because that's pretty much what happens. In most cases, it drops 50% the first day, 50% the second day, and then it may plateau or something like that. But you can, that's if they're eating nothing. If they're eating something, it's a little more unpredictable because you don't know how much fat they're really taking in. But generally speaking, I usually go by this 50% rule. It's like a half-life almost, I guess. The half-life of the triglycerides is 24 hours if you don't eat anything with fat in it. And so that, that's not written in a textbook, and please nobody quote me on that. But that's my general experience.
Well, I think that's very interesting to know, especially as we start looking at this patient's lab. So hopefully all of our attendees will keep in mind what you just mentioned as we move forward to review the labs. Shall we look at the labs?
Sure, that'd be great.
So keep in mind what Zahid just said.
So just to review, I'm going to have, the attendees can take a second to look through these labs. These were, again, obtained as we discussed after certain interventions. But the first line is the total cholesterol, the TC is the total cholesterol, and then the TG is the triglyceride level. As you come down, you see there's a non-HDL cholesterol, a very low HDL cholesterol, and I'll ask Zahid and Carol to sort of speak a little bit about that as we see this evolution over time. A low sodium, and looks like AST, ALT were okay-ish. Creatinine looked fine. Amylase, lipase were normal. No protein on the UA, no other findings on the UA, and glucose was normal.
So there's a lot here. Where do you all want to dive in?
Well, should we start from the bottom up? Maybe that's the most fun way to do it. So his lipase is normal. I mean, it's hard to explain. Maybe it's not pancreatitis, or maybe it is, and he's just one of those people that doesn't get high lipase, or he had it a few days ago and now it's okay because he's self-treated at home. That's really hard to tease out. I actually was expecting his AST to be twice as high as his ALT. The classic thing we're taught in internal medicine about liver function test patterns, but that's not the case. That still doesn't mean it's not alcohol related, just a little unexpected. The sodium being low, people with high triglycerides get the pseudo hyponatremia. That's an interesting thing. It's a lab phenomenon mostly with the assay. And usually the labs are smart enough to correct for it. So if you just ask them, they'll fix that. They can measure it properly then. So he's probably does not have diabetes. His glucose is 77. The non-HDL, we can go back to that. The HDL is, again, something I'm a little surprised by. I would have expected if he drank a lot of alcohol that his HDL would be, higher than just 7. But in the acute setting with triglycerides this high, who knows? And his triglycerides are in the 6,000s. That's actually much higher than I was expecting. I was expecting like 1,000s, and then I'd be talking about how it probably was 5,000 or 6,000 before. We just didn't catch it. It's possible he was much, much higher than this. It could have been 12,000 or something before he treated himself. And the cholesterol, usually you see the cholesterol high too, just because they're carried in the same particles of chylomicrons and VLDL. And so it also measures up high. this looks mostly like, a type 5 hyperlipidemia panel, I think, in the way I see it.
So you had brought up FCS earlier. How would this lipid panel look different than if this were an FCS patient?
Yeah, okay, so here's another tip, I guess, that's not written in books, so please don't write this down or quote me on it. But the genetically proven FCS cases that I have seen, almost all of them have a cholesterol to triglyceride ratio of 1 to 10. And that's because they accumulate almost all chylomicrons and very little VLDL. And the ratio of cholesterol to triglycerides and chylomicrons is at least 1 to 10. And so that seems to be something that that my observation is true for most pure FCS patients. Now, sometimes they get diabetes because their pancreas wears out, and you get kind of a mixed picture. So that's kind of my takeaway. If it's 1 to 5 ratio, I think of VLDL being accumulated. If it's a 1 to 3 ratio, or 1 to 2, 1 to 1, that's kind of more ideal, intermediate density lipoprotein cholesterol being increased, which would be more of a type 3 dissipated lipoproteinemia, although this doesn't look like that to me from the lipid panel.
So, I mean, I think you've made some really valuable points, though, in that if we start looking at our patients' lipid panels, and for this gentleman, also his age. So you were surprised, or you would be surprised if he's an FCS patient, given that he's in his 40s now and has not presented earlier with acute pancreatitis. We don't have a history of his triglyceride level, but we kind of are starting to see this picture evolve where maybe he's not FCS, right? Or we'd assume at this point, maybe he's not. And so if we can start looking at our lipid panel and start identifying the nuances of a lipid panel, that can help guide us, I guess, in the sense of what our patients might be dealing with based on the triglyceride to cholesterol ratio. Is that correct?
Yeah, again, not something to definitely write down, because I have been fooled before by some patients who take statins and their cholesterol is lower. They have a 1 to 10 ratio, but it's not FCS. It's it's just that they take a statin and it's lowered their cholesterol. But so again, not a hard and fast rule to go by, but sometimes it helps. There's a comment in the Q&A about CRP might be helpful. It should be high as well in acute pancreatitis. I don't have experience with that. I don't know, Taher or Carol, if you guys ever check CRP in pancreatitis. That is a good idea, actually. I mean, CRP is non-specific, but I guess it might be good to know.
I don't have any experience using CRP, but I haven't been in a clinical setting for several years, so that's why I haven't. Taher, how about you?
I sort of echo Zahid's comment about it being, non-specific marker inflammation. It would sort of, give you additional information about that underlying inflammatory process. I guess the question in my mind is always, if you get a mildly elevated or elevated level, what do you do with that information? How does it change the thinking? Does that lead you to say, okay, this is, those rare lipase normal pancreatitis? I mean, then we're really getting into some pretty rare etiologies, but I agree with you. I mean, there's no harm in checking. I think there's certainly to be able to, if you get a completely normal result, that may lead you down a different pathway. So that's definitely an interesting suggestion.
I do like your response, though, of thinking about what we're going to do. Like when we're thinking about adding tests, what is that going to help us with? What is that going to add in terms of building the picture for our patients? So I think that's important to, and not that I'm against looking at CRP, but I think that's an important point that you made.
The glucose, by the way, Zahid, the glucose being normal. So, we definitely know a lot about hyperglycemia and its effect on lipoprotein lipase and things like that. Do you see triglyceride levels this high when you have sort of run-of-the-mill diabetes, or is that really something that you'd only see if you have completely out of control, extremely high sugars?
Yeah, it's usually with the uncontrolled part. And a glucose level is there. I wouldn't rely on A1C, because A1C is a 3-month test, and let's say they quit taking their insulin a week ago, the A1C would fool you into thinking that they might be better controlled than they really are at the moment that you're drawing these labs. So the glucose level with the triglycerides is useful. But we're seeing plenty of diabetics get into this range of triglyceride levels. It's usually not just the diabetes though. I mean, it's almost always with obesity and maybe kidney disease or something else, but it certainly can get quite high.
So I think based on the labs, we're starting to have our attendees think through this, and someone is asking based on the lipid pattern, could this be type 3, the dysbeta-lipoproteinemia, which Zahid, I think you just mentioned that you're questioning that, but not sure.
Yeah, I mean, it could be. We can talk more about that later, but type 3 hyperlipoproteinemia or dysbeta-lipoproteinemia, lots of syllables there.
Right.
That's typically due to that happens in people with the ApoE2 genotype. And we can go into detail about the genotype as well if we want, but it may bore everybody. So most people with E2, E2 genotype are totally fine. In fact, their cholesterol is low, if anything, until they get some kind of hit. So it's certainly possible that this person with, maybe alcohol is his hit, or we don't know his diet. So it could be high saturated fat diet could be his hit. I would still think that the ratio of cholesterol to triglycerides would be closer to 1 to 1, 1 to 2. And some people even say 1 to 3. That would be my guess. Here, the ratio is not quite that, but it doesn't mean it's not. I mean, there could be multiple things going on as well. So I think it's a really good thought that this could be type 3.
So one more quick question from the attendees. Someone asked about TSH level. I don't think we have that information. Is that something, why would a TSH be important for understanding what's going on with this patient?
Taher, do you want to take that one?
Yeah, I mean, hypothyroidism in particular can cause a number of metabolic dysregulations, including changes that you see on the lipid panel, both in cholesterol, different cholesterol parameters, LDL-C, as well as triglycerides. I've seen a decent share of really severe hypothyroidism, including mixed edema, and you do get sometimes wonky lipid panels. I don't think I've ever seen anything this high. And Zahid, correct me if that's something that has been reported, complete sort of extreme elevations of triglycerides. I've never seen this with really severe hypothyroidism. Keep in mind that hypothyroidism, in addition to the labs, is more of a clinical diagnosis. And so if this person's otherwise feeling well on the outside, yes, there are these patients that I've seen myself who have, above assay TSHs and below assay free T4s and quote unquote feel fine, but just would be a little bit unusual for this clinical history with the changes that he's made at home. That's sort of just my reflections. I haven't seen people have these kinds of triglyceride levels with even really severe hypothyroidism. But Zahid, if there's anything else that you would add, please.
No, I agree. With hypothyroidism, it's by itself, usually you get just high LDL, but you can get high triglycerides. By itself, I have not seen hypothyroidism cause triglycerides as high, but in combination with maybe alcohol or diabetes or something like that, maybe it might get this high. We actually did this very interesting thing that I need to publish, but we looked at our county hospital and looked at the association of lipids and thyroid function. And with hypothyroidism, the lipids are kind of all over the place. Some people get high LDL, some people get high triglycerides, not 6,000s, but they get somewhat high, more of a moderate elevation. And so we haven't teased out why that is, but we do need to look at that and probably publish that soon.
So the only thing I would add is maybe because you mentioned typically if it is the ApoE phenotype, that hit, maybe the hypothyroid could sometimes contribute and be that hit that makes the ApoE phenotype present as the hypertriglyceridemia. Gosh. So we have some other comments from attendees, and I'm just going to, for keeping us on time, we don't have his HIV status, and we don't have an alkaline phosphatase status, but we do have some additional labs that we want to look at. So let's bring those up. His follow-up labs.
So this is after his self-directed intervention. So this is without pharmacotherapy. And this was the follow-up lab. So again, I'll pause for a second and have everyone just look through, in particular, noticing the really, dramatic change in triglyceride values. I'll let Carol and Zahid sort of highlight some of these changes over time. In particular, I'm a little bit perplexed about this non-HDL-C. What does that mean in terms of it being so high in the context of the triglycerides improving? And certainly, just like Zahid had mentioned, the sodium has now appears normal, even though it's always normal. But
So I'll just mention that his A1C does show he isn't dealing with a glycemic control issue, so that wouldn't necessarily be contributing to his elevated triglyceride levels. His ratio, I guess, Zahid, I'd like you to mention, or I guess talk more about what you're thinking about his cholesterol to triglyceride ratio at this point.
Yeah, this is super confusing, actually. So you would not expect the cholesterol to be twice as high as triglycerides like if I only saw this panel by itself, I would be thinking something like FH. Just this one panel on the 24th, I would be thinking FH, because maybe even homozygous FH, because that's really quite high. But having seen the panel before that, what often happens is that when the triglycerides start clearing out, when the VLDL and the chylomicrons start clearing out, you get kind of this flux and this strange patterns in cholesterol and triglycerides. And this may reflect just, the triglycerides clearing out, and it'll just take a little while before we can make some sense out of his lipid panel again. I probably wouldn't act on this. Like I wouldn't put him on a statin right away or do apheresis or anything like that. I would probably wait a little while and see where he settles down.
So how do you feel about his ApoB and his non-HDL-C, like Taher just said?
Yeah,
Does that start telling us some more information?
I mean, I'm not a huge ApoB person like many other people are in the lipid world. I usually just go by the non-HDL, but it doesn't surprise me. I mean, he certainly has a lot of cholesterol containing lipoproteins. He did before and he does now.
Right.
And that again may just be a part of the flux of clearing out the triglycerides, and this just shows up this way. I think somebody in the chat put FCH, which I assume means familial combined hyperlipidemia.
Right.
And that might be a very interesting idea, because some of those patients, in the classic descriptions, some patients flip between having high triglycerides to high cholesterol. And in the family, there are some people with high triglycerides, some people with high cholesterol. Now, no one has ever figured out the genetic basis of familial combined hyperlipidemia, except that some of them have LDL receptor mutations. They're actually FH patients. And so, that could be, but I think this is more flux related. I think this is just clearing out the triglycerides.
Okay. So Taher, unless you have anything else to mention, I'm going to keep us moving forward to make sure we have time to cover all of our slides. So
be great. Yeah.
Physical exam is going to help us build our picture of this patient, right? So definitely a lipid panel is important, but we want to know more about our patient in terms of physical exam.
So physical exam, you can see the vitals there. Mostly normal, BMI is just a smidge over, but again, that's just a calculation between weight and height. It doesn't necessarily mean there's an adipose-based disorder. Comfortable appearing on exam, no jaundice, no cardiovascular pulmonary exam findings. Abdomen was non-tender at this point, not distended, no masses. Thyroid was normal to palpation, no vascular bruits. Importantly, no lipemia retinalis, arcus, or xanthelasma. He did have increased muscular tone with male pattern hair loss. No acne was noted on skin exam. And Carol, if you click through, there's a finding on the Palmer exam, which are these Palmer crease xanthomas.
So why is that important?
So I think this finding is actually that the Palmer creases are yellow. It's kind of, it's really hard to take a good picture of yellow Palmer creases.
Right.
Because the lighting always affects the camera and the way the camera captures light.
It can also be difficult, like if this patient were in front of you. I mean, as a person who's trying to identify what's going on with this patient, you have the lipid profile information, and you start looking for physical exams that will really kind of be red flags for you. How difficult would it be to see these palmar creases in your office?
It's in your office, it's not so bad. You can always look at your own palms, and then, you know, assuming you don't have, assuming you're not ApoE2E2, you can look at your own palms, and then look at the patient and see what the difference is, or make a medical student show you their palms or something. I do that all the time, actually, mostly with Achilles tendons, but also with palms. And so you know, in the hospital or in the clinic, you can usually kind of see it. There's some good things here. He's comfortable. His abdomen is non-tender. You know, that's pretty good to see. And I think people in the Q&A, the last two comments are dis beta and type 3. So people kind of know already that this is pretty pathognomonic for dis beta lipoproteinemia.
Yes, we actually have some excellent. We've got experts in our audience, clearly. So let's go to the follow-up labs, unless there's anything else you want to mention here. I think that the point here, though, is the palmar xanthomas and how important that is for helping us rule out what's going on with our patient. So a final set of follow-up labs that were just recent, a little bit more recent. Are we getting closer to a lipid profile that would indicate dis beta lipoproteinemia?
Yeah, I think the most recent one from the third has about a 1-to-1 ratio of cholesterol and triglycerides, which is what you would expect if you're accumulating intermediate density lipoprotein, you know, something along that line. And the ApoB is high, and as Dan Sofer tells me, that this ApoB is, you know, not as high as you would expect if it was all LDL.
Mm-hmm.
And so, you know, I think that's an important point as well.
Mm-hmm. What about this non-HDL-C, and what would our target be for this gentleman? I mean, LDL-C here, we finally do have an LDL-C. Is that something we should pay attention to with this patient, and why or why not?
Well, so I mean, I do pay attention to it, but I think many people would say that, you know, it's not LDL being accumulated; it's intermediate density lipoprotein being accumulated in a patient like this. And so you want to try to target things that improve that, which you know, statins can do. Fibrates are, you know, in textbooks, fibrates are the classic thing to use in type 3. That they work really quite well. They can lower the lipids to pretty much your goals, and that's kind of the classic way to treat such patients.
And so from my understanding too, and I think Dan would not forgive me if I didn't mention this, but non-HDL-C really becomes our target for patients with dis beta lipoproteinemia, mainly because the LDL-C cannot always be, or typically is not accurate, even if we use something besides Friedwald, is it Martin
Hopkins, yeah.
Thank you. But in what I was reading in preparation for our case tonight, non-HDL-C is the recommended target for these patients, mainly because that's going to capture, ApoB sometimes is not as helpful either, because it's not going to necessarily capture some of those atherogenic particles, but the non-HDL-C would be a better target for us. Do you want to add anything to that?
No, I think you pointed, I think that's very eloquent the way you put that, yes.
Thank you. So Dan would be proud. So I know we only have a few more minutes. I want to make sure we have time to cover all of the information we want to tonight. Taher, do you want to talk through this?
Actually, because we only have 10 minutes left, I'm wondering whether we can just go more to, yeah.
Okay. I think the main thing here is that there is an app that if you are interested in using, that is available for you. And then the genetic testing.
So it did have genetic genotype testing done, which revealed ApoE2E2.
And is that typically what we have to have in terms of our phenotyping or genotyping for dis beta lipoproteinemia? Or can we have it with other? Does it have to be ApoE2E2?
Classically, it's E2E2. You know, you could also be E3 or E4, but if it's true dis-beta lipoproteinemia, in my opinion, it should be E2, E2.
And then even with that, kind of bringing back what you mentioned earlier, someone like this gentleman could have E2, E2 and it not present until that hit kind of causes the expression of that.
Yeah, in fact, and I didn't mention this before, but in my opinion, this is dis-beta lipoproteinemia plus probably alcoholic hypertriglyceridemia, like a type 5. So it may be a mixed type 3 and type 5 picture, which is why the first set of labs didn't show the more classic pattern of cholesterol or triglycerides.
So it's the APO, E2, E2, then the alcohol, maybe that was the hit that caused all of this to kind of express itself.
Yeah.
Okay. Anything you want to add?
There are some interesting comments and questions in the Q&A.
I was noticing that. So I'll take us to our next slide, and then maybe we can address some of the questions with what we would do next with this patient. But Zahid, did you see anything in particular in the Q&A that you wanted to address?
Yeah, you know, there's a question about the increased muscle tone. Was that an incidental finding, or is it a suggestion of anabolic steroids causing additional effects on the cholesterol levels? You know, when I saw that, I actually started thinking about hypothyroidism, because some of those patients can have increased muscle tone. Sometimes there's a very interesting finding. Some of them is so bad, if you just touch their abs, their abdominal muscles, I shouldn't say abs, their abdominal muscles, it'll start contracting. You know, it's pretty wild to see, but it does happen. And I'm totally blanking on the name of that phenomenon. But that's one thing that came to my mind. The other was lipodystrophy, of course, because they can have increased muscle tone too.
So, and just clarifying, this particular patient did not have that, but it could occur with some patients.
Yeah, absolutely.
Very good. Okay. So we have our confirmed diagnosis. So for medical nutrition therapy, I think I'll just spend a minute for that in terms of my viewpoint as an RDN. I really think it's important that we identify with this patient that he is not FCS, because that would influence what we would do with this patient dramatically. So with patients who have elevated triglycerides over 1,000, we may typically put them on a chylomicron clearing kind of diet, because we want to get those levels down. He did that on his own by basically going on soup and eliminating pretty much everything else. And so that soup is, I'm guessing it was a broth soup, very low in fat, like you were saying, Zahid, would be important. So, you know, by having a very low fat intake initially, that's going to help clear chylomicrons, as well as bring those triglyceride levels down. And then we have to start looking at the patients. We know he's got dis-beta lipoproteinemia now. For patients like him, probably carbohydrate intake would be more important, but we'd want to also make sure that saturated fat again is lower, not necessarily a total low fat, but making an emphasis on unsaturated fatty acids and keeping saturated fat intake low. If this person had diabetes, then that would definitely influence our medical nutrition therapy in the sense of helping them achieve glycemic control, lowering carbohydrate intake, not very, very low. I don't think our patients who have elevated triglycerides need to be on a ketogenic diet, but clearly a carbohydrate intake that is going to help bring down their triglycerides, but also quality of carbohydrates, which I think is always important. Decreasing added sugars to a very low amount, watching fructose intake, increasing fiber, so high quality carbohydrates, not just lowering carbohydrates, but really looking at the carbohydrate quality as well. So I'll let you to discuss pharmacotherapy.
Quick question, Carol, by the way. So for these patients, when you're sitting and you're counseling them about dietary approaches, whether or not they have diabetes or not, do you usually talk to them with sort of percentages of total intake? Do you give them grams of intake? Sort of structurally, what does that look like when you sit down with the patient, you're counseling them?
That's a really good question. I think the main thing is to do what works best for the patient. A lot of people, percentages don't make any sense to them at all. I find talking about grams in a day makes more sense. I mean, it's almost kind of like, you know, I used to talk with patients about keeping it like a checkbook. You know, if I've got this many grams of saturated fat or this many grams of carbohydrate to spend in a day, then that tends to make more sense with patients versus percentages. And you can kind of talk broadly and say, if you want to consume 30% of your calories coming from carbohydrate and 40 from fat and 30 from protein, but then you have to bring that down to what does that actually mean in terms of grams? And then really, what does that look like? And having tools like pictures to help people kind of see, like plate methods, can be very valuable as well. Definitely figuring out what works best for the patient though. Good question.
And Zahid, I guess, I'm really intrigued about this question about atherosclerosis imaging. I've heard some stuff about type 3 and the atherogenicity of those excess particles. So just wanted to see what your sort of perspective is, whether this is the 44-year-old or somebody much younger or somebody much older. What do you usually do in terms of your approach for these patients?
Well,
all right, real quick, we have about 3 minutes. I just wanted to make sure we are aware of that. Go ahead, sorry.
Yeah, maybe I can try to answer very fast and then we can go through some of the Q&A because there's several comments there and we can get to them. But anyway, I have to admit I've never actually ordered atherosclerosis imaging in a type 3 patient. I just usually just treat them with therapy. And if they have chest pain, then we do, stress test or coronary CT or something like that. And so I just go past the, doing something like a coronary counseling scan. We can go through some of the comments and questions.
Okay. I didn't mean to rush you, Zahid. I really didn't. There are some great questions here, or points. Someone mentioned that running gel electrophoresis for pre-beta mobility. Is there a commercial lab that you're aware of that does that?
I think you can ask Mayo Clinic.
Okay.
They've done some things like that for us before, but I don't know about pre-beta mobility, but you can probably ask them to do something like that.
Excellent. My very good friend Wahida Kamali also mentioned that adjusting macronutrient distribution and using MCT oil can be helpful in terms of lowering carbohydrate intake for patients. So that could be a whole webinar on itself, but I just wanted to make that point. Someone just asked about ethnicity, and is that important?
Well, I'm not sure ethnicity is important, but it may give some clues to their socioeconomic status sometimes. I mean, I really shouldn't say that, but it may give clues to their diet, I guess. And we shouldn't make any assumptions. We should always ask the patient about their diet, but I don't know what this patient's ethnicity was.
I don't either, actually, but I do think your point about making sure we individualize it and understand their cultural background and just, I think that's been a theme that we've mentioned this whole evening, is really identifying what's going on with this particular patient and individualizing whether it's medical nutrition therapy or pharmacotherapy, what's appropriate for that patient and their needs. Should we worry about cascade screening for this patient as we wrap up tonight?
Probably not, since you do have to have E2, meaning you have to inherit it from each parent. It's biallelic. The chance of passing that along is low, but not zero. So, I would probably screen their spouse or whoever is their partner. But it's probably not a big deal.
And I do want to make the point, I remember Dan mentioning that this person does not have siblings. I believe only one parent is still living. So again, just looking at individualization, this patient doesn't necessarily need cascade screening because of his situation. Someone else might be different, but the E2 phenotype being so rare and being autosomal recessive also plays into that. Okay, as we are wrapping up, any final comments, advice? Anything else for our audience tonight, gentlemen?
No, thank you so much for moderating this. Thank you, Dr. Safar, for such an excellent case. It is really, really wonderful hearing all of your perspectives, and thank you to all the attendees who came in and heard this wonderful case.
Yeah, this is wonderful. There's 60 people who are attending. That's outstanding.
I agree. I learned so much just talking with you all before tonight as well as tonight. And it was a sheer pleasure of being part of this with you too.
Wonderful. Thank you so much. Have a good night, everybody.
You too. Thanks everyone for